Thank you for the opportunity to speak here today. A number of names, a number of faces I know. And today, I've been asked to talk about a topic which I believe is very pertinent. It's a lot that I see in my office, and I'm certain in your capacity, in your field, you see a lot the same. The way I thought I would approach this is, for education purposes, is how to teach you how we think as spine surgeons when these conditions present to our office. For starters, in the cervical spine, there are 7 cervical vertebrae. The first 2, called the atlas and the axis respectively, are anatomically very different from the lower cervical spine, which we define as the 3rd through 7th vertebra, C3 through C7. So when we are looking at this, there's an example of an MRI. This would be the anterior throat, posterior the backside. Anteriorly, the gray boxes represent the vertebral bodies. The wafers between are the shock absorber discs. Posterior, or behind it, you have the neural elements, the gray being spinal cord, the white on either side of it, spinal fluid. Looking at a cross-section, you have bone and disc anteriorly in front. The bony arch in the back is called the lamina. You have 2 paired facet joints, which allow motion, and those form the boundaries of your spinal canal. That center, the yellow, is the spinal cord, and at every disc level, individual nerve roots lead through an exit canal called the neuroforamen, traveling into the upper extremities. Radiculopathy. When somebody comes to the office and you really don't have a workup, you want to define what the clinical presentation is. Radiculopathy is compression of an individual nerve root. Here on the MRI, the backside rope, I call it the fried egg for patients. Cord is the yolk surrounding white fluid. This is a herniated disc. Off to the right, sparing the cord but compressing the nerve root. Radiculopathy. In myelopathy, this is mechanical compression of the spinal cord. So here, again, throat, back of the neck, white boxes, bones. You can see pretty good looking thick disc level here. The intervening ones, 4, 5, 3, 4 through 6, 7, markedly degenerative, spurs forming, resulting in compression of the gray, the spinal cord. Radiculopathy or myelopathy can be caused by the 2 most common conditions. One is a disc herniation. What happens here is the outer tough layer, the annulus, tears. It allows the inner shock absorber nucleus to escape. In this particular example, it sort of goes off to the side laterally, compressing the nerve root, so it could lead to radiculopathy. On this one, a side view, the herniation is very large, it's central, and it compresses the spinal cord. That's how it can cause myelopathy. Spinal stenosis, the other common condition, occurs when there's narrowing of the spinal canal, and it is resulting in nerve root compression symptoms. This too, if it's off to a side, we took radiculopathy. If it's central, like in this particular case, this is spinal cord compression, it would result in myelopathy. So once a patient walks in the office, you have to obtain a detailed history. You start with their symptoms, and you also try to obtain information. Is it a traumatic etiology or atraumatic? Is it new? Is this the first episode? Or is it been chronic for multiple months? Or is this, or they had it in the past, and it's sort of resolved? Disc herniations can be traumatic or atraumatic. After age 30, 35, our spine ages, we start to see tearing in the disc, the annulus, which could result without trauma in an atraumatic herniation. Obviously trauma, overloading the disc, can result in acute tear in the herniated disc material. Spinal stenosis does pre-exist. It's a degenerative condition, but the question then becomes, was it aggravated by superimposed trauma? In radiculopathy, where there's nerve compression, the patients report symptoms in the upper extremity of burning, numbness, tingling. They may note weakness in a specific muscle of the arm. Upon physical examination, everything is going to be decreased. They will have decreased sensations, so light touch or pinprick. They could have decreased muscle strength when we grade it from 0 to 5. And they could have decreased reflex specific to the nerve being involved. The picture over here is kind of important because every nerve that exits into the arm is responsible for innervating a specific muscle, controlling a reflex, and providing sensation to a specific dermatome. So, depending on which nerve is involved, you will have different findings upon exam. So for example, if someone has a herniation at C5-6, the sixth nerve would be involved, it could weaken the biceps, you have decreased sensation going into the thumb and index finger, and weakness perhaps in the biceps as well. If somebody has a herniation, let's say it's C4-5 to the right, but bending the left arm pain, that would not correlate. So it's important from our point of view to correlate symptoms, physical exam findings, and diagnostic studies. Another test that you may see be performed in radiculopathy is called Sperling's. Think of this as the next straight leg raise. You already have compression of the nerve, whether it's due to an osteophyte or disc. One way to perform it is you have the patient look up, rotate their head and neck over the affected arm, and you're narrowing the exit canal, so your pinching was already pinched. It provokes a decreased pain. Another way to do it is you have the patient turn their head to the affected arm, press down on the head. Again, you're compressing what's already compressed, so they report radicular pain. Myelopathy, because this involves the spinal cord, is truly a different bird. Because it's the cord, it not only can affect an arm, but it could affect the nerves that go to the legs and the bowel and bladder. The natural history of myelopathy is deterioration. It doesn't just get better. So in most cases, it's almost a complete staircase. There's a deficit. A few months later, it gets worse and worse. However, 10%, would be a very rapid decline, and we don't know who's going to fall into that whole 10%. So when patients come in, they frequently discuss with us that their legs don't feel coordinated with their brain. They don't want to react, so they can have a wide-paced, unsteady gait. Ask a spouse, it almost is a little bit too much to drink if they're unsteady. Not uncommon, they can have problems with hand dexterity. So if they lose their coordination, they can have difficulty buttoning, they can have their handwriting changes. More advanced cases, they complain of bowel and bladder problems, incontinence, and they can note some wasting of the hand muscles. Upon the physical exam, again, because there's cord compression, we do see decreased sensation below the level of the cord compression, decreased muscle strength, but because again, you still have the nerves to the lower extremities, you get about 1 per 4 up to 4 extremities. However, here, because it's the cord, not the individual nerve root, your reflexes, your biceps, triceps, your Achilles patellar become brisk or hyperactive. You have normal reflexes that we see, which normally are inhibited unless the cord is compressed. It's Babinski's, clonus, which is, if you will, you move the foot up and down and it just rapidly beats. Or a meat sign where you press on the head, they report electric shocks to the lower extremities, and Kaufman signs. So here's just an example of a Babinski. You stroke the bottom of the foot with sort of a sharp object, and the big toe withdraws, goes to the sky. A Hoffman's is if you tap the middle finger, you get a reflex contraction of the thumb and index finger. One that we tend to see when the cord compression is higher is what's called finger escape. The patient puts their hands out like this, their fourth and fifth fingers sort of drift away. Finger escape sign. Another one that we see when there's cord compression high, the hands are involved, it's a grip release. Normally, you should be able to do this like 60 times in a minute. If you start seeing the patient fatigue, it indicates cord compression. Once you arrive at the working diagnosis of radiculopathy or myelopathy, you have to start with the workup. Plain x-rays, including an AP and lateral minimum, are very important. What we tend to look at is the individual vertebra, the disc heights between, overall alignment of the cervical spine. You should have a normal soft C-curve called lordosis. The x-rays, as you can see here on the left, are excellent for showing any degenerative changes in the disc. You see the big spurs narrowing. You can check out the bony alignment. Again, you want a nice soft curve. Plain x-rays can pick up some congenital anomalies, and in rare cases, destructive processes such as tumors or infection. The go-to exam, however, is an MRI. The MRI is great for showing disc pathology, such as herniations. It tells you the number of levels involved. It tells you if an individual nerve is being compressed or the cord itself is being compressed. For example, here, throat, back of the neck, you can see multiple level degenerative disc disease with spurring, the gray spinal cord being compressed. Additionally, you can actually see what's called myelomalation. This is scarring of the spinal cord due to compression. The spinal cord should be nice and gray. I don't know if it's the light, but if you see some white streaks within it, that indicate scarring called myelomalation. You have to let patients know regarding the ultimate poor prognosis. It's also very good for differentiating other kinds of conditions that can mimic cervical cord compression, such as multiple sclerosis or, God forbid, tumors. The use of an EMG-NCD. I tend to use this when I'm not convinced that the patient's clinical complaints of pain, numbness, tingling are from a cervical spine etiology. You're looking for peripheral nerve problems, carpal tunnel, cubital tunnel. If somebody gets hurt at work and their arms pull, you worry about a brachial plexus stretching. This study is excellent for that. In certain cases, patients may complain of numbness, and it may not even be due to nerve compression. It can be due to an underlying neuropathy that you can see with diabetes or thyroid disorders. A myelogram plus myelogram CAT scan is an alternative to an MRI that can't be performed. Patients who have a pacemaker, you can't put in the MRI. Previous instrumentation in the area of surgery, you may not visualize the neural elements well. The way the myelogram plus myelogram CAT scan done is think of your nerves as a garden hose. If you will, water normally flows through. They inject the dye into the spinal fluid. And if my hand is some compressive pathology and I press on the hose, you're going to see on the films after where my fingers have indented or resulted in the nerve compression. Treatment. When we're talking treatment, let's start with radiculopathy, whether it's due to herniation or stenosis. Radiculopathy is more forgiving than the cord compression, myelopathy. So in these cases, if someone is neurologically intact, no motor deficits, you can treat these patients conservatively for a minimum of 6 to 12 weeks. Medical management would include a short dose of narcotics for acute pain, muscle relaxants, oral steroids to sort of really reduce the inflammation, also known as prednisone or metreldospam. Once that's completed, anti-inflammatories are effective. Physical therapy is useful because you can educate the patient on the natural history. They can do some strengthening of the muscles of the cervical spine. Traction, unlike the lumbar spine, is effective. You can't apply enough force between the vertebrae to open up an exit canal, make room for the nerve to reduce pain. Epidural steroids can be utilized in radiculopathy. The concept is we're injecting a little bit of steroid involving the inflamed nerve root. Through reducing inflammation, you can then hopefully alleviate the symptoms. They can be performed 2 weeks apart for a maximum of 3. In radiculopathy, when do I recommend surgery? Again, if they have 6 to 12 weeks of non-operative care, pain is jazzing up their life, you're going to offer them surgery. If, however, somebody comes in with, say, a short duration of radiculopathy, but their examination shows significant motor deficit, you're going to act much sooner. Because in that case, it's sort of declared itself. If during the course of your follow-ups, you know they're a little weak, the next time 3 weeks later they're weaker, again, you're going to pull the trigger for surgery sooner. In myelopathy, this again, cord compression. An aggressive approach, is needed because of the natural history, that 10% that can decline rapidly. The results of surgery for myelopathy are much better when the patient presents with less neurological deficit and a shorter duration of symptoms. So when somebody comes in the office and they have significant neurological loss, weakness in the upper lower extremities, difficult time ambulating, we recommend surgery. If it's not bad in the beginning and then it progresses, you're going to recommend the surgery sooner. I will state that epidural steroids are absolutely contraindicated in treatment of myelopathy. If you think about it, there's very little room available for the cord. It's being compressed. It's like putting water in a water balloon when you're a kid. You never know if that little bit of water is going to make it pop. It can result in neurological devastation. Now, once you determine the need for surgery, I'm sure all of you know there's an anterior from the front of the neck approach or posterior. It's indicated Anterior approaches are indicated for radiculopathy or myelopathy, whether it's due to herniation or stenosis. You can approach pretty much the whole cervical spine from the front, C2-3 down to the C7-T1 thoracic junction. It's very useful for addressing up to 3 levels of disc pathology. To do that, to address more, it's an extensive dissection, and there's a lot of fusion levels that have to heal. As a result, you can end up with a failed fusion more rapidly. It's indicated in cases of kyphosis. Kyphosis is the loss of the lordosis. It's almost like your chin now is going towards your chest. The reason for that is that a lot of times the individual nerve compression is being draped behind the disc level, so you have to correct it. Corpectomy, which is also vertebrectomy removal of the vertebral body, is performed very well from the front, and it's indicated when the compression of the neural elements is not only at the disc space level, but behind it. So you have to resect some of the vertebral body between the discs to achieve adequate decompression. So briefly, with the anterior approach, you go in from the front, you perform a discectomy, you remove any osteophytes or bony spurs, you do, corpectomy if required. And once the decompression is done, you perform the fusion. This is to provide stability and restore the alignment. 2 types of bone grafts available are taking a piece from your front of your hip, iliac crest, or more commonly allograft, which is cadaver bone thoroughly tested by known donors. The use of instrumentation, such as anterior plates and screws, increases the fusion rate. The more letters you do, the better the fusion rate with the instruments, and it helps maintain the alignment. So just briefly in this picture with an anterior approach, small horizontal incision in front of the neck, identify the spine, the bone above and below, the vertebral bodies. We then start removing the disc piecemeal from front to back. Because behind it, back in here, that's where the neural elements are, or in the nerve roots. Once you've decompressed it, you then put in a piece of bone to fuse or weld it together. So here on the right side is an example of an anterior discectomy and fusion. You can see the gray being the disc areas. In this case, the disc was removed front to back. A high-tech plasticky type of cage filled with bone graft is placed where the disc used to be to perform the fusion. The plate and screws are applied to the front to provide stability and promote the fusion rate. Example on the left, this is more extensive decompression. If you see here boxes of vertebra, what's done here is this patient's missing one. A vertebrectomy, corpectomy was performed. So the fusion was done from the bone above to the bone below. The cage is placed with bone graft, and then again, plate and screws to provide stability. An alternative in the last 8 years or so is disc replacement in the cervical spine. It is indicated for 1 or 2 levels of radiculopathy, not myelopathy, secondary to disc herniation or stenosis. However, prerequisites for this technique is that it has to be a relatively healthy disc that isn't degenerative. The facets can't have any arthritis, because you don't want to put something moving in there to promote further arthritic change. The advantage of this is that you are not fusing it. As a result, you maintain motion and theoretically prevent stress transfer to the disc levels above and below to prevent potentially further surgery in the future. Here is an example on the right. You sort of see the individual vertebra, discs. In this case, this is a disc replacement. What happens is it's inserted into the body above and below. There's a bearing surface in here, and motion can't continue. It's almost like a hip or a knee replacement kind of concept. In certain cases, the anterior approach is not feasible. When would you go from the back? There's really 3 types of procedures. 1, laminoplasty, indicated for compression myelopathy. Other, laminectomy and fusion, again, for myelopathy. Foraminotomy is you're unroofing an individual nerve root, so it's indicated for radiculopathy. Endolaminoplasty is used for cases of core compression when there's greater than 3 levels. Remember, we were talking for the front, you can do up to 3 levels. This would be useful if you have 4 or 5 levels of the body. It mandates a normal cervical alignment, and neck pain must be minimal, because with this, you are not fusing it, so you will not address any component of significant neck pain. The advantage of this procedure over the laminectomy fusion is there's a shorter recovery because there is no fusion. So the way this is done is you make an incision in the back. Again, here's the front, anterior. posterior spinal canals here, the gray is where the original lamina is. We would cut one side of the lamina near the joint, hinge it open on the other side. So if you think if you're putting a book on a table, this is the spine, doing one of these, that allows you to adequately decompress the spinal cord. So backside view of this drawing, the cord or the lamina is cut to one side, and it's open, hinged over to provide room underneath for not only the nerve roots, but the spinal cord. To maintain the opening of the lamina, we now use little titanium plates, and that just prevents the hinge from closing down, resulting in further myelopathy. Laminectomy infusion is also indicated for myelopathy greater than 3 levels. After you do the laminectomy, we then would weld the bones together. We reuse bone graft to promote perfusion, and the instrumentation provides stability and increase the fusion rate. In this case, laminectomy infusion is indicated when a patient has a lot of neck pain, okay, the laminoplasty wasn't, or they have a loss of their normal alignment, because if you do just the laminectomy with a loss of alignment, it can potentiate further malalignment. So in this case, see, looking at the back, the lamina is cut on both sides this time. The idea is then, once it's cut, you remove it, and it almost comes out with a lobster tail from the top and bottom, so that what you've achieved is an adequate decompression centrally. Infusion would then be done by putting the rod screws and bone graft in place. Perform anatomy from the back. Again, it's useful for radiculopathy, where there's 1 to 3 levels. This is almost like a lumbar microdiscectomy, a small, say 1-inch incision, go to the involved side, left versus right, and make a little bony window, and that adequately decompresses the nerve coming out. In this case, you can see it's useful when there's a minimal neck pain. Again, if there's a lot of neck pain, you're not going to achieve the result of the neck pain. It's great for radicular arc pain. Here's the bony arch of the back, a little bony window's made. To free it. And if there is a piece of disc underneath the white, you can remove that as well. The advantage is there is no need for infusion. In a handful of cases, we may have to go both front and back in the same patient during the same surgery. This is indicated when the compression is significant both in the front and the back, and you don't feel you can adequately decompress all of the nerve compression. It's also used in cases where somebody undergoes multi-level orchectomies, the plate and screws in the front are not sufficient, they'll fall apart, you roll them over, and you do a fusion in the back to promote stability and a fusion rate. And in cases where you have kyphosis, you may have to go from the front and the back to address the compression. Now I thought, with all that being thrown at you quickly, I'd work through a few examples to kind of let you know how we kind of think. Here's an example of a 50-year-old male, 1 year of neck pain, right arm radicular pain into his thumb index long fingers. He's reporting 6 months, however, of progressive clumsiness and dexterity problems in the right hand. He has diminished strength, right biceps, wrist extensors, and a positive Hoffman's. So with this history, I'm thinking obviously there's radicular pain, but you have a Hoffman's. It's an upper motor neuron finding we shouldn't see. He's reporting clumsiness in the hands. So working diagnosis is myeloradiculopathy. The patient's plain x-rays, the lateral view, bones, disc, you can see some narrowing between 5, 6, 6, 7. The MRI, cutting through the discs, if you will. Again, the Friedek cord, normal spinal fluid, there's insufficient, there's narrowing here. If you don't have enough fluid, that's moderate stenosis. But if you look at the level below, the stenosis is bad, it's actually compressing the cord. So in this case, 2 levels of spinal cord for myeloradiculopathy, we elected to perform a 2-level anterior cervical infusion. Both discs are removed, spurs removed, infusion is done with a cage, bone graft within, and a plate applied. This is a side view, and this would just be in the case of like looking in a mirror. You see the plate, the screws going into the vertebral bodies. The second example is that of a 29-year-old, 5 months of right arm radicular pain. He does have some diminished sensation in his triceps and wrist extensors, decreased sensation in C7. So when I went back to earlier, how everything has to correlate, the triceps, wrist extensors are innervated by C7, decreased sensation, C7. spinopathic or upper motor neuron findings. Plain x-rays of this younger gentleman show that disc heights are very nicely maintained, even at 6'7". However, when you look at the MRI, again, individual vertebra, other bones, gray boxes, the wafers between our discs, a huge herniation at C6-7. You can see how it's compressing. This view here at axial, back of the head, neck, raised cord. This is, believe it or not, that's what radiologists get jobs. Left side, right side. Here is a chunk of disc off to the right. Here you see the nerve on the left escaping. This one isn't. So in this case, you have a herniated disc with C7 radiculopathy young. And in this case, we proceeded to do a discectomy and a cervical disc replacement. Again, kind of showing how it looks in the beauty of this young person. It preserves motion, hopefully less future problems at levels above below. Another example is that of a 65-year-old who's complaining about steadiness with walking. He started to fall. He had to use a walker for ambulation, which lasts a few weeks. His exam revealed what we call the myelopathic gait. It's wide-based, it's shuffling. He has hyperreflexia in his extremities and the reflexes. Again, upper motor neuron, there are two bricks, that's cord compression, and the Hoffman sign. So the working diagnosis here is myelopathy. Looking at this view, you can see the throat, back of the neck, again, the vertebra. This is to give you an idea of sort of a nice looking disc. You can see multiple discs are very narrow. Additionally, I've used the word kyphosis to see how you've lost the alignment, the normal curve. This is almost like a mini hunchback deformity, kyphosis. So in this case, the MRI shows two levels of significant compression. And in this case, the working diagnosis was myelopathy. So to address all the problems, we went anteriorly, because it's two levels. Instead of just doing the discectomy, we had to correct the kyphosis. So we removed the vertebral body, did a corpectomy. You can see the markings of the cage filled with bone graft. The plate is applied to the front. In the last case, the dad of the patient with bilateral upper extremity pain, radiating to the hands. Again, exterior problems, clumsiness, walking difficulty. Examination did reveal hyperreflexia in both lower extremities, a positive Hoffman sign, weakness in the right triceps. So again, this is a case of myeloradiculopathy. It's a mixture of the two. The plain x-rays actually show, again, throat, back of the neck, marked degenerative disc disease 3, 4, 4, 5. The patient had prior portal fusion was 5, 6, 6, 7. MRI on this side shows, again, pretty severe compression, E4, 4, 5, as you can see over here. And at C6-7, there's also some compression. So because this involved going from 3 down to 6-7, this is 4 levels. There was myelopathy and some radiculopathy. So what was done to address this is we went posterior, did the wide laminectomy to decompress the cord and the individual nerves, did the fusion by placing the bone posteriorly and instrumenting it with what we call lateral mass screws. So in conclusion, disc herniations or stenosis cause radiculopathy, nerve compression, or myelopathy, cord compression. There's different surgical approaches, anterior or posterior, that are determined by the number of levels, the alignment of the cervical spine, whether it's just nerve radiculopathy or myelopathy, cord compression. In general, whether it's anterior or posterior, the results are better in radiculopathy surgery. Why? Is because of the cord involvement in myelopathy gets less forgiving. I thought with that, now I could let you be more direct with your questions in terms of anything you'd like to know. Sure.
Can I ask sort of a philosophical question?
Absolutely.
So it has to do with the fusion between shoulder pathology and cervical pathology.
Yes.
So many times we have clients that come in and they have what they perceive to be shoulder pain. It radiates down, maybe up into the thumb, and radiates up.
Okay.
And then they go see a sports medicine doctor. The doctor says, well, it's a shoulder problem. And they go see a spine doctor. They go, no, it's a neck problem.
Okay.
But what's the best way for us to identify whether it's shoulder versus neck? And I know that there's testing, but philosophically, why is it that this continues to happen? That that these two areas are confused?
I think that number one, when you have shoulder pathology, if you will, think of the way we're put together. You have muscles from the neck that attach to the shoulder, or your scapula, your wing bone. If you have a neck problem, you can't get referred pain towards the shoulder. You also have a shoulder problem, you can get pain ascending up to the neck, because the same muscles attach. The best way to do, if you will, when you're wondering is it neck or shoulder, is truly on a physical examination finding. If somebody, for example, has this early sign of producing the pain, that's neck. If somebody with range of motion of the shoulder reproduces the pain, it's going to be shoulder. Very commonly, in shoulder problems, they don't like to move the painful shoulder, so it's almost like the Napoleon sign to keep their hand here, because they're trying to guard it. Okay? In cervical pinch nerves, they're trying to make room for the nerve, so they actually do this type of thing, because it makes room for the nerve in the exit canal. So I think that's one way, physical exam. And then you obviously order the diagnostic test to confirm it. Yes?
I've seen a lot of pain treatment and referrals for injections, constantly, even in the absence of a positive EMG, even in the absence of a positive MRI. Is there any time that epidural steroid injections are appropriate for someone who doesn't have positive findings, MRI or EMG? Why would you refer someone for that?
Well, number one, no cord compression for epidural. Right? If there's true documented nerve compression, whether it's a herniation or an osteophyte resulting in radiculopathy, they've tried some therapy, the pain's not abating, then yes, I would send them for that. I would not send them, however, for epidural injections if the MRI is clean. It's not, there's nothing there. If you're really worried about, again, if the application worried about some inflammation, treat it with a medral dose pen, less risky. And if it's not a cervical spine, it's still systemic, we can address some inflammatory process that may be causing it. Yes?
Doctor, what's the life expectancy of a disc replacement?
Great question. It's relative, unlike joint replacements that have been around since the 60s, most longest term follow-ups have been about 8 to 10 years. They seem to be holding up pretty well. They really do. Because unlike a joint, there's no real synovial fluid which kind of wears the disc material out like it does in the hip and knee. So we're tending to see it's lasting for at least 8 to 10 years. Yes?
So doctor, the cervical disc replacements are very recent.
Yes.
About 10 years ago, 12 years ago, we had the lumbar disc replacements, which were arranged for a period of time. And if I remember correctly, longevity studies coming out of Europe, they basically not seeing it.
Right. I think part of the reason the lumbars never took off, the indications for lumbar disc replacements, number one, was nobody could have radicular pain. It was mild degenerative disc disease. You can't have bad joints in the back, the facets. You can't have nerve compression. You can't address that from the front in a lumbar surgery. So, over all the years of spine, you do this type of fusion, front, back, this. Operating on back pain is not a good idea. The results are not very good. Because we really can't necessarily identify where the source of the back pain is. Is it muscle, ligament, disc? Disc replacement in the neck, however, is done as an alternative to fusion. The indication is true radiculopathy, nerve compression. Here, you go in, you remove the disc material, take away the compression, but instead of doing the fusion, you're putting in the mobile part. It's the indications that have separated cervical from lumbar. And I think that's one reason the lumbars get taken off. Other thing, response to that, revising the cervical disc, much easier than doing a lumbar re-up with the great vessels aorta. Very dangerous. Yeah.
Is there any push with the FDA to allow more than a 2-level cervical replacement?
At this point, there have been no long-term studies. I think they do them a little more liberally in Europe,
Yeah.
but not in the States. Honestly, that's kind of good. The FDA is a little more strict. They want to see, because when all these studies come out, you have to make sure it's as good as the standard, like a 2-level fusion. Yes?
Is a myelogram better than an MRI anyway, or is it not really tell you anything?
I think the MRI is probably more specific and gives you the information you need. Again, if somebody can't have an MRI, get the myelogram CAT scan. If you're uncertain what you're seeing, one place the CAT scan or a myelogram CAT scan is a little better is seeing bony spurs in the exit canal and neuroforamen. The CAT scan picks that up a little bit better. CAT scans by themselves can also be the test of choice. If someone's had a fusion, not certain it's healed, much better than plain x-rays. It'll tell you if the fusion is healed or not. Okay. Any other questions? I will also say this, that in terms of returning to work and things like that, a lot of this truly is predicated upon one's occupation. Yes?
Thoracic disc herniations. You didn't talk about that, but I realize it's not subject.
What about?
Yeah, what can you do for them?
Okay.
Anything you can really do?
Yes. Thoracic disc herniation, similar to the neck. You have spinal cord, individual nerves. If the spinal cord is compressed, they manifest symptoms, they need surgery. There's different approaches, sort of, if you will, going through the chest. If it's further lateral, you can kind of sneak in from the side. If it's just a pinched nerve, that, like everyone in the arm and leg, you do have nerves that go to the ribs, you can inject that if there's no cord compression. But I will say this, that if there's truly cord compression, neurological deficit, thoracic herniations have to be surgically addressed. But they're far in between. Yes?
So you talked about MRIs, CT. We didn't talk about discogram, and not a lot of people use it, some do. What's the difference between a myelogram and a discogram, and why is one better than the other?
A myelogram shows anatomy. For example, is a nerve compression, cord compression. A discogram is a provocative test. I like to call it the most subjective, objective test we have. It's very dependent on the patient's response, the person performing it. They were used a number of years ago, in particularly lumbar. They're out of vogue with the neck because they're having cases where the disc is ejected, it's causing neurological deterioration. I will say the following, that with cervical interventions, you're not operating on neck pain. If you can't tell on exam or an MRI or a myelo-CT where the source of the pain is, the nerve pain, I don't think doing surgery on that patient would be efficacious. So I would not recommend a discogram. Yes?
In your second example of the 29-year-old firefighter with a single-level cervical
Right.
replacement, how is his 3-year, 5-year history? Is he back to work as a paramedic?
Oh yeah, he's back to work. He did really well. Any others? Yes?
Are there any particular types of trauma that you often see in cervical disc herniations?
It could be lifting, it could be motor vehicle accidents. If you're talking like that type of trauma, it could also be office knees. Falls from heights, more major trauma causes a traumatic herniation as opposed to a disc that's been wearing out a while, that was healthy, and that herniates without trauma. Definitely.
Someone with a previous cervical fusion subsequently develops adjacent level disc collapse, disc disease. Is that person a candidate potentially for a subsequent disc replacement at that new level?
It depends what's actually there. If the disc above or below the fusion is very worn out, you can't do a disc replacement. If it's only neck pain, you don't do a disc replacement. You need radiculopathy, nerve compression. Predominantly neck pain, which is what we tend to see in patients that have had fusion, because the adjacent level tends to take a while to develop. It's more slow process. In those cases, the disc is usually degenerative and just extended fusion. If, however, somebody had a fusion that they bought a hot disc above, then maybe you consider the disc replacement. Yes?
When you do second opinions or surgeries or IVs, what do you need
when I'm treating a patient, I need to see the films. Because I'm examining the patient, I'm listening to their history, I can correlate. When I see there's a 2 millimeter protrusion at this level, 1 millimeter here, then you look at the films, not good. And then when they say these little protrusions result in no stenosis, that's why you need to see the films. Yes?
Just so in case it wasn't clear, could you please kindly remind members of the defense bar, people representing insurance companies, that a patient has a severe myelopathy? Is that something you can take your time to evaluate, do utilization review, and have long conversations about, or is that sometimes the patient needs to go into surgery?
I can't speak for the process of how things proceed, but I would recommend very strongly that if the diagnosis is myelopathy, that it proceed quicker, much quicker. Yeah, it can portend a poor outcome for the patient if there's a delay. Well, if that's it, thank you very much.
All right, everyone, just hang tight and we'll have our next speaker up momentarily.
Ray, why don't you tell her to moderate?